This talk, and I've written some pieces about it, was informed by a few very good books. Anybody seen this book, Leading Physicians Through Change by Jack Silverson? Paperback book, very, very nice read, very easy read about how to try to get physicians to change the way that they're doing things. Anybody read this one, bestseller? I thought it was very helpful to sort of get grounded and try to understand myself and my colleagues in how we respond to change. This is even newer, Inside the Physician Mind, and I highly recommend this. You could read this on a plane ride. And what I like about this is it actually compares physicians and how they think with how administrators think. Okay, so for instance, they gave the example, when a physician says, we need to fix this now, this is a problem. What do we mean? We mean now. An administrator will probably be thinking in terms of the next budget cycle. Right? So we really are different. Physicians also think about their patients. Anybody heard the phrase, the apostrophe problem? So physicians think about the patient's, with the apostrophe before the S, best interest. Administrators think about the patient's, plural, and then apostrophe, best interest. Do you see what I mean? We're one by one trying to do the best for each patient in the bed. The administrators are often thinking about hordes of patients, a hospital full of patients. So it's just a very good read, interesting to compare and contrast. And I felt like I understood better what they think of me, how I'm thinking, how they're thinking, and so forth. Then there's a great white paper on IHI.org, the website, Institute for Healthcare Improvement, on its leading physicians in a shared quality agenda, but it was actually very much how to sort of move physician behavior, and I learned a lot from it. And by the way, I don't know if you know this, the IHI website, they have lots of white papers on flow, on quality improvement, and you can just download them for free. You don't have to join anything, pay anything, so it's a great source of resources for you if you don't already know. So today, a little bit about the craft of medicine, sort of understand how our profession's changed and what many physicians' expectations, how they've kind of been squashed. It's not really the deal we thought we were signing up for. Talk about how medical education and physician culture don't really put us in a position to be good at change. If anything, it makes us rather staunch, stuffy, and conservative. Then we'll talk a bit about standardization and why that's such a hard sell to docs. And then change management. And if you are leaders in this room, you should be making a study of change management. There are books written on it. Change just doesn't happen. And just because you tell your team we're doing it this way doesn't mean that it's going to happen that way. And so there are really strategies for bringing about change, and it's worth becoming a student of this. Our colleagues in business know this. They study leadership technique, they study change management, and we should as well. So craft of medicine. So we actually, from the turn of the century forward in healthcare, physicians, we almost have been like a guild. People say, you know, we were almost like a bunch of blacksmiths in a way, the way we approached our colleagues and the way we operated. And the deal was an individual physician with lots of knowledge, experience, and training, putting the patient's needs first, right? And I think most of us do care desperately that the patient in the bed is going to get the best care. We could craft a unique plan for that patient. Okay, this is the craft of medicine. So you would try to find out the best way to take care of that particular patient and customize it. And the promise, I grew up watching Dr. Kildare. Anybody else? I blame my career choice on that guy. If he'd been less handsome, maybe I wouldn't be here, I don't know. But that this approach will produce the best possible result for each patient. Does it? Does it? With each one of us as cowboys practicing medicine the way we see fit, is that a plan? Does that work in today's environment? No, it actually doesn't. We don't always deliver. And we realize that there are very many evidence-based guidelines that are getting just all out ignored around the country by practitioners. So this doesn't actually really work. Then I love this, and I picked that cover for a comic book, you know, purposefully because it's just so provocative. So we're going to put our patients first, we're going to maintain our knowledge and skills, and we reserve the right to police ourselves. Would you dig it if a lawyer said it? And yet this is what we thought we could do. We'll just look out and make sure that we're practicing quality care. And we'll police ourselves and we'll monitor our own performance. And then honestly, it does not really work. So then there was the give and the get. What many of us thought, in particular if you trained in the 60s, 70s, early 80s, I'm going to study for lots of years. I'm going to get this way expensive education. I'm going to care about my patients and study hard and try to keep my skills up. I'm going to work hard. And you're going to leave me alone and let me practice. I'm going to have a good income, prestige, and good outcomes. Did any of this play out for people? Actually, if you have this, can I come there? Because I think that physicians have been, in many ways, disappointed on a lot of these fronts. We certainly don't have the autonomy that we thought we would have. There are more people regulating what we do and how we do it. Incomes are definitely stagnant. I mean, it's a good job, I will say, but you know, compared to some other fields you could have chosen for the years that you train, we don't always have the prestige. Sometimes I feel like I'm the bad guy in the room just by virtue of what I do. But to be sure, we don't, doing it one doctor with one patient at a time, crafting what we're going to do, doesn't yield the best outcomes. It really doesn't. So it's changed. You know, here we were little blacksmiths, you know, or silversmiths, whatever you want to think, in our guild, and now it's changed. We were a craft-based profession, and now we're moving towards a profession-based practice. And groups of peers are kind of coordinating and setting standards for how we're going to do things. So much for that autonomy we thought we would get. At the same time, statistical process control, process improvement, and so forth was growing up in other fields, and it's impacted what we do. So what we thought we were getting into, I mean, is anyone surprised? Is your career in medicine what you thought it would be 25 years ago, if you've been in it that long, or even 15 years ago? I'd suggest to you there are a lot of things that we kind of didn't count on. And the nursing colleagues, I'm not saying don't feel sorry for us, I'm just saying might be worth trying to understand this. And for you physicians who are trying to lead other physicians, just try to sort of understand this, especially perhaps your practitioners who are older who said, this isn't the deal I signed up for. So just kind of understanding that context. So the other thing is, medical schools, if anything, sort of select for people that are going to be autonomous thinkers, very independent, going to want to own the show. That's what we've always selected for in medicine. And this is Brett James' terminology. They teach craft-based autonomy. That's what he says. Heroic individualism with an attitude. You know, we're going to do the right thing for our patients. We're going to do it our way, and so forth. If there's goodness in my heart and purity in my motives, it can't go wrong, right? And this is what we thought that we were going to get into. And yesterday, I thought it was bold that Kevin would talk about cookbook medicine, because for a long time, that was anathema, wasn't it? Like, ooh, cookbook medicine. I'm not doing cookbook medicine. I'm a physician. I can think. I'm going to make my own decisions. So the whole ground beneath us is changing, if you will. And we're training this guy, but I want to suggest to you that he's rigid, he's authoritative, he's autonomous, and that's not really working in this world, because now medicine's a team sport. So a lot of things have changed, which I think make it difficult in leading physicians, and you have to sort of understand what's going on. Another issue is physicians have always been willing to own their mistakes. They'll own it. If I'm competent, then no mistakes or bad things are going to happen. And the idea of system problems is a little bit foreign to physicians. They still don't think about system causes for problems. They're still more than willing to own when something bad happens to a patient. And that's not really a functional model in this day's world either. They'll say, I made the mistake. And they're not willing to think about it in terms of operations and systems and how could the team have done this better. If I could lead physicians, there's 3 big areas that I want to lead them to, just as generalizations. To accept standardization, it's not a bad word. It's actually going to help us, I believe, in the next 10, 15, 20 years of our practice. To embrace technology that is workflow-minded. And actually, I just wrote a paper with Steve Davidson at Maimonides for the American Medical Informatics Association. It's a white paper on how the electronic health record and IT has to support workflow and not get in its way. And then to be part of a team. And we really do not train physicians to be team players. Unfortunately, we are taught to be the cowboy. you know, and we're, as if we're, you know, we're in charge of everything, we're the boss, nothing's negotiable. And again, healthcare is a team sport, and especially in the ER, it's a team sport. And so we have to sort of change what we've been trained and change our mental model so that we can function in this new world. And the biggest constraint is the culture. And I love that yesterday Brent talked about culture a little bit. It's very insidious, and he talked about it as values, attitudes, beliefs that translate into behaviors. This is physician culture. A pattern of shared assumptions learned to solve problems, physician culture. And this is what we know about physician culture. It is very conservative. It's a very conservative. If you compared physicians to architects, attorneys, other professions, we are a conservative lot. We don't buy into standardization typically. It's, you know, I'm a well-trained physician and I will figure out what to do for this patient. So in fact, we've sort of rejected it in the past. We tolerate lots of variation in everything, you know, 20 different ways to treat vomiting, for crying out loud. Can we just agree and standardize that little thing? And we block change, and in the past that was probably a good idea because many fly-by-night treatments came along, and I'm convinced that patients were protected by physicians being conservative and saying, wait a minute, you know, let's not go down that road. But now things are changing, especially with operations. They need to change faster, and maybe this blocking every change at every turn is not a good characteristic. And they build a reservoir of resistance against change, just really want things to stay the same. There's a very interesting article in the British Medical Journal by a woman named Sexton in year 2000. And she did kind of a deep dive on cockpit crews, in particular pilots, and compared them to OR crews, in particular surgeons. Have you heard of this study? It's really pretty interesting. So you can get very readily a pilot to say, I get tired, and when I'm tired, I make mistakes. You know, two very basic premises, and they build their sort of work schedules and everything else they do, teamwork and so forth, around those two assumptions. I get tired, and when I'm tired, I make mistakes. They couldn't get surgeons to say that they got tired or that they ever made mistakes. Are you surprised for what you know about many of your surgical colleagues? But see, totally different culture there. Totally different culture. And I would suggest to you that the first culture, the pilots, that serves them better. So they've got a crew, and often the crew will keep them from making mistakes. And by the way, this is the logic behind med teams training and med teams work that's sort of seeing a new life now in hospital-based practices. So the other issue, would anyone quibble with the idea that there may be a physician morale problem right now in this country? What do you think? A lot of people are writing about it. I think that's probably very likely to be true, because look at the deal they thought they were getting into. I'm going to train all these years, and as you know, it's a really long time. It's a very long time, you know, a dozen or more years to train to do this work. And I'm going to have lots of debt, but then I'm going to control my professional life. And now they've gotten there, and they have anything but control of their professional life. So there is that. There's lots of pressure from business pressures, there's regulatory agencies and so forth, and most physicians, if you talk to them, feel like I'm doing more for less with a lot more risk. And it really, they're in the box, we're in the box, or that's how it feels sometimes. It's old model, I'm going to see patients and I'm going to deliver quality the way I think it should be done. New, I've got to be accountable, I've got to delegate authority, I can't run the whole show, I'm interdependent with other practitioners on the team, I'm patient focused. Old model, I want autonomy, I want protection from market forces. Remember, in the old days, early physicians had this. You were not influenced by the market at all. The insurance agencies paid you, the government paid you for the work that you did. And entitlement, meaning if you did this, you got referrals, you got patients sent to you, you were able to have a practice. And now that's really changed. We are driven by market forces like anybody else, and compensation is linked to performance. It's really, the deal has changed. So, cookbook medicine. Now here's what's so interesting. A physician who rails against clinical guidelines and standardization of any sort gets in the cockpit, and what happens? They've done some studies about this, that physician pilots are fine with checklists, standardizations, doing it the same way every time, no individual decisions made, I'm doing it by the book. but they put their white coat on and they have issues with it. So very, very interesting dichotomy. And actually there are a significant number of physicians who are pilots. So interesting how they move from one environment to the other and have a different notion about it. I have to mention this. So this is an aircraft carrier flight deck, right? And the average age, you know what the average age of the crew guy is on that? With these planes taking off all day long? 19 years old. Do the planes biff? You never hear of it. Why? Everything is standardized. Everything is standardized, from the language, the choreography, the steps, the order that they're taken. Everything is standardized on that, in that little operation. And that's why it works. And that's why and so they have Ashley and frickin' Frack. And they're doing okay with them because they've standardized everything. And so one of the cases I'd like to make to you is you don't just accept standardization and try to get things protocolized in your department for you. You're doing it now for Ashley and frickin' Frack because they're very inexperienced and they need this standardization. How many of you have a standard one antiemetic if they're puking? Anybody? Wouldn't that be a good idea? So they can't make medication errors, so everybody knows what's going to happen, you know. And so, as you know, I'm a firm believer in that, in standardizing these kinds of things. Also, it makes it easier for you. So now you're doing something. Maybe you're talking on the phone. Maybe you're trying to read an EKG, synthesize labs. Now the nurses know, Dr. Smith, room 3 is vomiting. Can I give her some Zofran? What if that was already there? They're puking, they can have Zofran. Doesn't that just seem like a good idea? You could actually make your life easier by having some of these things standardized. Do you know this? 1954, 1 in 1,500 deaths due to anesthetic complications. By 2000, because of standardization, 1 in 250,000. Don't you think that's astounding? That's just remarkable. And I know we're not an OR. We have way more variation in patients, situations, cases that we're doing, but I think it's worth considering what we could standardize. There's now less than 1 fatality per million takeoffs. In medicine, do you know this? In terms of reliability, we only get it right 8 out of 10 times, typically in healthcare. We're not, you know, would you take your car to a shop that would get it right 8 out of 10 times? So standardization, you get a shared baseline where it's possible, evidence-based practices. Is there evidence which antiemetic is best? Not that I know of, so just pick one. You could pick Compazine, I wouldn't care. For my department, just could we do it all the same? You're going to eliminate variation. You can measure and learn over time if everybody's doing it the same, and it is safer. So Brent James said, it's more important that you do it the same than that you do it right. And he truly believes this. When you do it, error rates fall, costs fall, because if you're not stocking 25 different medications, you know, could you pick a glove? Could you pick an absorbable suture and a non-absorbable suture? And this is what we're going to use in our department. Start thinking about your shop, about wouldn't it be possible, and are you really surrendering so much by giving up these little teeny choices? In many ways, it would make your life easier. So now it's not, Dr. Wilson, do you want Proline or you know, do you want Ethlon? What do you want? You know, you don't have to make a choice. They just get it. So standardization, it's hard to make the case to physicians. I'm just curious. How many of you are going, no way to standardization in your ER? Anybody feel that way? You can say. I mean, there are very, very many people that feel strongly. I think the tide is turning, the tipping point is turned, and physicians are getting more comfortable with this idea of having things more standardized. But it's counter to that paradigm that you learned. I'm going to make a choice on every single patient in the bed. One by one, I'm going to pick what's going on with them. So it's antithetical to that. And when you try to bring about a standardized protocol in your department, people will always object by exception. They'll think of the one case where doing that would be a bad idea, and your counter needs to be, yeah, but for the other 99% of the patients, it's better if we do it this way. It's better if we do it this way. So instead of designing for the, what does Brent calls it, designing for the onesies and twosies, so if there's 1 or 2 patients out of 100 that this standardized protocol maybe wouldn't be the best, what about the other 98 or 99? Let's design for them. So understanding why it's hard to move physicians in their behavior, understand their education and training, their culture, and this whole craft of medicine that they were weaned in. Now, Now, I wonder why that didn't show. You guys have it in your book. There's that graph that you've actually seen a couple of times showing the adoption of change. The point being that there's a curve. And you should know in your department, do you know this? You probably got some innovators, some guys that are always coming up with really cool ideas, right? And then you've got the guys that are more willing than others to take a chance and try something new. If you can get them on board, then you can usually pull the rest over the curve. And then do you also know your laggards? You know who laggards are. Never met a change they didn't hate or didn't want to block, right? Every department has them, and you probably know who they are. So if you know who your first two groups are, and you treat with kid gloves the laggards, you can usually make this happen. And mind you, I'll tell you what, just so you get where I'm coming from, and I think I said this yesterday in terms of quality improvement, I've been doing it since 1997. I have failed at very many projects. When I have failed, it's because I haven't rolled it out and played it in a mindful way. I've just tried to roll something out without any data and without doing the necessary steps. And it's usually failed because my physicians wouldn't buy in. So they talk about having a change team. And it's not like you're going to go and say, well, you're our sponsor. But just so you know, having one of these big cheese guys behind you really helps. They throw their weight around, and just by being present, dropping down in the ER when you're trying something new, usually I always think of the CEO in this role, and it's a good way to sort of get yourself aligned with that guy. And in your handout, by the way, there's a more in-depth description of the role of the sponsor. And sometimes you're if it's a big change, like if you're trying to do adopt a border, which, by the way, if any of you need Peter Vicellio's protocol, email me. I've got it as a PDF. I'll send it to you. Somebody else was asking me for pain protocols. I sent that to them this morning. So if you need anything that I've talked about in particular, flash me an email and I'll get it to you. The psych stuff I don't have on this laptop, but if anybody wants the psych protocols from Intermountain, I'd be happy to send it to you. Then you need a change agent. And I usually think of this, the nurse manager can be a great change agent. She's getting down with more of the details and trying to move the project, bringing energy and encouragement and so forth. And then you need a champion. So it's got to be one of the docs in your group that is willing to just ride this with you and try to talk it up and give some support to the project. Sometimes if you could take somebody who's typically a naysayer and get them on your side, that's hugely powerful for moving the group, But do you see how there really is some design to making change happen in a department. Yesterday I gave you some ideas and specifics on how to roll out a project and the steps you do. Now I'm talking about making the cultural thing happen and moving people. So few strategies for dealing with physicians. Get them involved early. If you're even thinking about doing something new, you got to flash it by the docs early, often, over and over. Acknowledge their concerns, acknowledge their... So sometimes they're going to present you with some stuff that's really legitimate, like, wow, we didn't think about that. You're right. We better address that before we try to roll out this project. And get, as I said, know your leaders and early adopters and get them with you early on. Be careful how you package and frame the project, and I'll tell you a little bit more about that. And always value physicians' time. That's one thing that is the disconnect. So when there's a meeting about some new initiative and the administrators show up and the nurse leaders and so forth, they're getting paid, eh? When there's a meeting and they want a physician there, what's that guy doing? Not only is he not getting paid, he's giving up hours. He's giving up shift work that makes him money. And that's like the elephant in the room in my book. No one's talked about that. Yeah, you need the physicians, but they have absolutely no incentive work-wise to show up in the room. And I feel like that's a mismatch that we have to somehow correct. So when you're talking to doctors, if you tell a doctor, if we change this, we're going to save money for the organization, does that move physicians? It absolutely does not. In fact, I would suggest you that probably turns them off. That turns them off. But if you say you're going to improve patient outcomes, make it better for the patients, physicians, they turn on to that. They listen to that. They care intensely about that. If you tell them it's going to make your life easier, and I want to say this over and over, whatever project you take on must be easier than what people are doing now. Do you get that? You have to be crafting things that are easier than what they're doing now. Those projects will fly. You craft something that is harder than what they're doing now, it's going to falter. So I want you to always be thinking about the particulars of what you're going to roll out. And then you have to sort of understand not only organizational culture, but physician culture. When I pick a project to roll out, and especially if you're just starting this work with your docs, I pick something that's going to make the docs look good. I think it's a good strategy and show them how things can work. Something that's low-hanging fruit, going to work. One of my favorite projects that I do when I go on is a door-to-doc project. I'll tell you just quickly about this. So we had a great outcome with this. 2 hospitals at Intermountain. We totally changed the culture, improved it door-to-doc times from over an hour to under a half hour, okay? And how did we do it? Got a change team, got the nurses, everyone on board. We had a change package that was rolling out. I had the entire staff on board for this thing, and all planned to launch, changing the way we intook patients and improving door-to-doc times. The physicians would not let me talk to them at their meeting. Could you believe it? Yes, knowing physicians, you can believe it. They're like, we don't want to spend any time at our meeting on that. Plus, we're sick of hearing how great LDS Hospital is. We don't want you to come. So there I was, but you know, never say die. I conducted this quality improvement project by mail. I sent them articles on door-to-physician times, and everything it was going to do for them, lots of paperwork, and then the most important thing, I sent them data. Their data about their door-to-doc times, okay? Which, can I tell you, this is like ding, 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 take-home point. Physicians are moved by data, in particular their own performance data. It is the most powerful tool that you have as a leader. Because as I said, they're a competitive lot, they don't want to be an outlier. I don't want to be the only one that's mucking up on this particular measure. And they will change their behavior and fall in. So entirely by mail, the only quality improvement project, by the way, that I've conducted entirely by mail with physicians. And look what happened. Statistical process control, by the way of looking at data. The bump up, where there's very long door-to-doc times, that's December. You'll forgive December. And that was before we started. We actually began launching in January. So they got their mailings in here and their data about how they were doing. And here is February, March, and it's held. It's under 30 minutes at the other hospital as well. Pretty impressive, huh? Turned on a dime, showing doctors how they're performing, and they changed their behavior. Yes?
No process change, you're saying?
No, there were a couple of... The biggest process change, though, was people being aware of the wait, paying attention to it, and the staff actually helped be the drivers because they would go, Dr. Wilson, this patient's been here almost 30 minutes. So they would help. So no, there were process changes to be sure, but this is a group that had really resisted the idea at all. This was a group that had said, we give great care, they can wait. So, and it really changed the culture, and it's held, and I've got data for years out. It's never been over 30 minutes since. So big change. But could we have done it without the physicians on board? All the nagging by a nurse, you know, the patient in room 6 waiting 30 minutes. If the docs aren't on board and going to play, it's not going to work, eh? But then, so get this is the other nice thing that happened. Complaints fell, left without being seen fell. The CEO was thrilled and came down and said to the very directors that wouldn't let me talk to them, you're doing a great job down there, Bill. You've really turned things down around there. And I'm just, because Brent James always says, you know, one of the greatest strategies is to not care who gets credit for the work. So I let these guys ride the success, and they've been my friends ever since, by the way. So the other thing you can take advantage of in terms of physician change is they're lifelong learners. So you can cash in on that and understand that they are willing to absorb new information and want to respond to it. But I believe change and improvement should be physician-led, evidence-based when you can, and data-driven. And change has to be better than what they were doing before. It's got to improve workflow and minimize waits and delays. So summary of your strategies. Understand their culture. Try to make the case to them for standardization that it'll be better for them. Talk to them with data. Data moves behavior. Start with a win-win project. So can I tell you, with those 2 hospitals, I started with that, and it's been other things, one after the next, always working on a project. But the launch was this door-to-physician times because it made it better for them, made them look better, less complaints to deal with. I mean, it was just win-win, very easy actually, and that's where we started. Remember, a change team, you're not going to do it by yourself, which many of you as leaders may have been doing this work by yourself. Have that change team, understand that learning culture, and that feedback loop is so important because physicians respond to data, especially theirs. So I'm going to end with this quote. You can get a lot farther with a kind word and a gun than a kind word alone. This is Al Capone. And this is my version of that. You can get a lot farther with a kind word and some data than with a kind word alone. So anyway, any questions or comments? Does that help a little bit? I mean, do you have some ideas now for when you go home, how you might move the guys in your group?